Hello guys, this is a 5 year of surgery. This is a course of hospital surgery. I'm glad to see you there. And for me, you're a doctors right now. 2 years will be so fast for you that don't think about them. Okay, today first topic about hospital surgery. This is a chronic ischemic heart disease. Small action, but very interesting, how I think, and very important for you. You need to remember that atherosclerotic lesion of the coronary arteries is a progressive disease. At an early stage of development, lipids are incorporated into the intima, forming atherosclerotic plaques surrounded by fibrous tissue, and this is accompanied by a gradual narrowing and decrease in the lumen of the coronary arteries, and consequently decreases in the blood supply to the myocardium. In some cases, fibrous tissue contains calcium deposits, and you see a page. Just first two picture. In first picture, we can talk about early stage. What about late stage? At a late stage, there is a rupture of the tissue above the plaque, its ulceration. A platelet clot forms above the damaged plaque, giving rise to a blood clot, a further decrease in the lumen of the arteries, and a myocardial infarction. Pathogenesis. As the coronary arteries narrow, there is a discrepancy between the myocardial oxygen demand and the possibilities of its delivery. In this regard, angina attacks occur. According to statistics, about 1/3 of the population dies from atherosclerotic coronary artery disease at the beginning of coronary heart disease. Spasm of coronary arteries prevails, accompanied by ischemic pain during physical exertion. Angina pectoris or at rest. Angina pectoris at rest. Subsequently, myocardial infarction very often occurs. Classification. Atherosclerotic lesion of the coronary arteries may be limited or diffuse. Obturation of their lumen leads to focal myocardial ischemia, which can be reversible or irreversible. Myocardial infarction. The most important symptom of ischemia are chest pains and angina pectoris. Patients are concerned about attacks of chest pains, which stop after taking nitroglycerin. Rhythm disturbance, heart palpitations, clinical manifestations are very variable. According to the classification of the New York Heart Association (NYHA), the severity of chest pains and the course of chronic coronary heart disease are divided into 4 classes. Class 1. There are no distinct symptoms of the disease. Class 2. The appearance of angina pectoris after heavy physical exertion. Class 3. The appearance of angina pectoris after light physical activity. And Class 4. Angina pectoris at rest. Patients classified in Class 1 and 2 do not experience severe angina attacks. The disease does not prevent them from leading a normal lifestyle. We call it stable angina. In the case of an increase in the class of the disease within a short period of time, there is a reason to talk about progressive angina pectoris, which significantly worsens the prognosis. Unstable angina. In the late stage, ischemia occurs at rest and becomes refractory to the medication used. We call it unstable angina. The prognosis at this stage of the disease worsens significantly. There is a risk of a heart attack or sudden death. In a significant part of patients, the disease does not develop according to the above classes, but can immediately manifest itself as a heart attack or sudden death. Sometimes asymptomatic myocardial ischemia is observed and the disease is recognized only in the late stage. ECG, an electrocardiogram obtained at rest and with measured physical activity on a bicycle ergometer, provides important information. Electrocardiogram analysis allows to determine the severity and localization of myocardial ischemia, the degree of conduction disturbance, the nature of arrhythmia. Color ultrasound, like Doppler, and echocardiography examination is of great importance. It allows you to determine change in the contractility of the myocardium. By the nature of the movements of the walls of the ventricles of the heart, it is possible to identify the focus and prevalence of myocardial ischemia in zones of hypokinesia, akinesia, or dyskinesia, in the zone supplied by the narrowed branch of the coronary artery. Slowing down the speed of movement of the ventricular walls during myocardial contraction is called hypokinesia. The absence of movement of the ventricular wall is called akinesia. With an aneurysm of the heart at the time of contraction of the unaffected myocardium, the scar-altered area protrudes. We call it dyskinesia. ECG, echocardiographic examination, makes it possible to determine the systolic, of course dystolic, and residual volumes of the left ventricle. Ejection fractions, minute volume, and cardiac index, and other indication of hemodynamics. MRI. Magnetic resonance imaging provides the most accurate information about the state of coronary circulation. Selective coronary angiography. To clarify the degree and localization of narrowing of the coronary arteries, the state of peripheral and collateral circulation in the heart muscle, selective coronary angiography, including chinorentgenography, cinema rentgenography, is performed. This is important for determining the localization and extent of the narrowing before and during surgery. Radionuclide research. Radionuclide studies make it possible to clarify the vastness of the myocardial lesion by the degree of accumulation of nuclide in the myocardium. In picture you see that we use radionuclide intravenous, then we take a patient into HAMA camera, and after we look at picture to understand where radionuclides accumulate. Yeah, that's right. Myocardial infarction. Progressive segmental narrowing of the coronary arteries inevitably leads to myocardial infarction. Remember it, infection. The fate of the patient depends on the extent and localization of the infarction, the degree of dysfunction of the heart and internal organs. Surgical treatment is indicated for stenosis of the main trunk of the left coronary artery by 75%, with stenosis of 2-3 branches of the artery and clinical manifestation of NIHAC with class 3 and 4. A decrease in the left ventricular ejection fraction of less than 50%. Urgent indication. An urgent indication for myocardial revascularization surgery is unstable pre-infarction angina that does not respond to conservative treatment, as well as pronounced stenosis of the left coronary artery, stenosis of the proximal portion of the anterior interventricular branch of the left coronary artery, and signs the blockage is accompanied by extensive myocardial infarction. With stable angina and unable to drug treatment, the operation is performed as planned. The result of the operation is the restoration of coronary circulation in 80–90% of patients after surgery. The phenomena of angina disappear, the risk of myocardial infarction sharply decreases. The main method of surgical treatment of atherosclerotic lesions of the coronary arteries is coronary artery bypass grafting, or bypass. The operation consists in creating one or more anastomosis between the ascending aorta and the coronary artery and its branch, distal to the occlusion site. A section of the tibial vein is used as shunt, vena saphena magna. Coronary artery bypass grafting. There in picture you can see any variants of this operation of this surgeon. Coronary mammary anastomosis. In 1964, Dr. Kolesov first performed an anastomosis between the internal thoracica and coronary artery below its narrowing. He called it coronary mammary anastomosis. Currently, the malleable sections of the artery, arteria thoracica interna or arteria epigastrica, are often used for angioplasty. According to a number of indicators, angioplasty using an artery is superior to coronary artery bypass grafting using a vein segment. Prerequisites for successful myocardial revascularization are: first, it is a stenosis of the coronary arteries, 50% or more, with good patency of their peripheral parts. Second is a sufficient diameter, at least 1 mm, of the peripheral section of the coronary arteries. And third is preservation of myocardial contractility, live in myocardium, distal to arterial stenosis. In recent years, with the development of endovascular X-ray surgery for the treatment of narrowing of coronary vessels, dilatation has been used with the help of special probes with balloons that are inserted into the lumen of the artery. Filling the balloon with a contrast agent, they achieve stretching of the narrowed segment of the artery lumen and restoring its patency. The success achieved during the dilation can be secured by installing a stent. The choice of the surgery method depends on the nature of the coronary artery lesion and the patient's condition according to the NIHA class. Attempts are being made to destroy the atherosclerotic plaque with a laser beam. When a patient develops a pre-infarction condition due to thrombosis of a narrowed coronary artery, emergency coronary angiography is performed to detect the localization of a thrombus. Then streptokinase is injected into the coronary artery to the site of its blockage through a catheter. In this way, they achieve recanalization of the coronary artery, reducing the ischemia zone. Subsequently, coronary artery bypass grafting is performed as planned. Thank you for your attention. This is a first lecture. be happy and don't forget about me. Thank you, bye bye, see you soon.